she's also the director of Creighton's Health Law program. But before going to law school, Professor Dineen actually spent 10 years as a practicing nurse. She worked in the ICU, and then after working in the ICU, she dealt with a lot of pain management. So currently, she works around issues regarding opioid and drug policy, as well as the impact on decision-making on patients with highly stigmatized conditions like pain or substance use disorder and serious mental illness. And today she's going to present about how harmful prescribing habits and improving opioid policy development for evaluation. So please welcome our final presenter, Professor Dineen.
I'm going to do this because I will inevitably drink somebody else's water while I'm in here. This is the point of the day when if I was cooler or more self-secure, I would say, let's do a yoga move or dance for a minute. But I'm not, so I'm sorry. So I echo everybody's thanks. Sincerely, thank you so much, Professor Hines and Professor Weeks, for inviting me. Thank you so much to Erica for, again, the amazing work you have done, and to the whole Law Review editorial board. I look forward to working with you. Okay, so just a quick roadmap. Basically, I'm going to give you just a little bit of background on patients who are associated with opioids, which will become clearer what I mean by that in a minute. I'm going to talk a little bit about some thoughts about what kind of decision-making influences may have led to some less than fully thought-out policy developments, in my opinion. And then I'm going to suggest just one tool that might be useful to help correct for some of those decision-making errors as we begin to come back now to some of those policies that have been in place for a while, or as we develop future policies. Okay, so this is the slide at which, as some of you have seen already, but I use it to just illustrate how complicated this problem is. It's a public health problem that's a morass of multiple public health problems. Involves, of course, the serious public health problem of pain, substance use disorders in general, opioid use disorders in particular, mental illness, particularly serious mental illness. There's a tremendous amount of comorbidities, so overlap in conditions in all of these categories. And this is not to scale because I'm just not that good. I'm sorry. But another problem that I think has been largely ignored is the problem of suicidality that overlaps and overlays those other three diagnoses. Okay. And I want to tell you a few presumptions I'm making, which I feel necessary to state because sometimes are misunderstood. So. Presumption number one with all of this work is that the harms I am talking about as associated with opioids is the harm of premature death or the harm of morbidity, meaning sickness, lost productivity, lost days, etc., regardless of the source. So prescription opioid, multiple drugs, so-called illicit drugs, it doesn't matter to me. I'm concerned about the overall harms to people, okay? I also want to point out that I avoid the word legitimate with respect to patients at all costs, and this is because I feel that that word's been appropriated in a lot of this literature, that any patient who has a substance use disorder, who may be engaged in so-called red flag behaviors, because of that substance use disorder, is as legitimate a patient as any other, and it detracts from, I think, the dialogue when we don't acknowledge that. And that I continue to hope, one might even dare say that I'm optimistic, that we can craft policy and practice solutions that don't sacrifice any of those patient groups for the benefit of the other, right? I think, but we have to be mindful of this. We have to be particularly mindful of this as we go forward and take care of people on the professional level and as we craft policy, particularly because of the nature of the deep-seated cultural, historical, legal, and other structural barriers that have contributed to extreme stigmatization of these patients, right? So, to the extent we can break people down into different categories, again, it's a bit of a false distinction with many people, but we've known for years, I personally experienced it, that providers do not want to take care of patients, particularly with chronic pain, right? When I worked in this kind of clinic, and I worked with a neurosurgeon who was sort of the last stop for pain, refractory to all kinds of other treatments, I don't know how many people would say to me, oh my God, how can you work with those people, right? And this is just a quote from a really wonderful qualitative study by Megan Crowley-Matuka and Gayla True. They were doing a study on something else, and they got so many comments, and the notion of taking care of patients with pain came up so much in their qualitative interviews. They did a whole nother study using those. So we were struck by just merely noting a slight research interest in pain in the most general terms elicited powerfully charged emotions, prompting clinicians to offer up expressions of frustrations like, ugh, pain patients, I hate those back pain guys. I just want to turn and run when I see them, and what a waste, the kind of energy they spend trying to get their meds. It makes me sick. And these are like the doctors and nurses talking to them, okay? And they were probably being, minding their words a bit, knowing who they were talking to, because I've heard much worse, right? So we also know we have a long history of provider avoidance and outright disdain for people with addiction. And it's not getting any better over time, I don't think. But so we've got a quote from 1962, just explaining how physicians just want the addicts out of the office. They see it as a police problem, not a healthcare problem. It's interesting because if you go back, before the turn of the century, it was seen as a healthcare problem. So things hadn't evolved in 60 years, and I want to believe they're getting better, but I don't know. So, and this is just another quote, that doctors have notorious contempt for drug addicts, and they make little effort to conceal it. They're considered fair game for jokes and slang. And this is not all that surprising, right? Because particularly with people with substance use disorder, this is the sort of biases are baked in the cake, right? Because of multiple things, but just in the legal world, right? We've got now a 104-year history in the United States of courts and other enactments saying to doctors and other healthcare professionals, here's regular medicine, that includes everything else, and here's this little special category of addiction medicine, but it's not like real medicine, and we're not going to really train you on it, even though it's more prevalent, right, than diabetes or anything else, right? But you can, most people that are practicing physicians right now got out of med school with like maybe a couple hours on addiction, right? And I know of all the providers I've seen, none of them have been good about actually talking to me, like actually asking questions like they do about my diet and everything else, right? So we avoid these discussions because this idea that it's a moral malady is just deeply ingrained in us, despite sort of our intellectual knowledge. And then finally, the fact that we continue to criminalize the possession of substances is the legitimized, state-sanctioned stigmatization of addiction, right? So this is tough. This is tough. And, I didn't work with patients with addiction for treatment, because of course I worked with patients with addiction, but of course I was just as guilty as most other providers at the time. I took care of patients that had pain, and I took care of patients who had traumatic brain injury, I took care of patients that had all these other things. Like, well, of course, I just know by the numbers, a lot of them had that problem, but we just ignored it, Okay. And then when it comes to opioids, prescription opioids, we've got this ongoing narrative that's been running through and I think has been made worse, admittedly by the actions of some physicians and other prescribers as well, so I'm not saying they're innocent. But you've got this ongoing cultural narrative about the sort of social deviant addiction, people with addiction, and you've got a medical narrative that's superimposed on that about drug-seeking patients, and then another narrative on top of that about the foolish, deviant doctor who got fooled into feeding somebody's addiction, right? And that belief has run through many things and continues to run through the language of criminal cases and administrative hearings, even though we know, if you look at social science, even a skilled provider does no better than about 53 to 54%, so just a little bit better than chance at discerning who is telling the truth and who is not. Now, everybody has a self-serving bias about that, so everybody, including me, and I've read a lot about it, is probably sitting there thinking, but I'm pretty good at telling who's telling the truth. But even after training for like trying to detect, people are really no better, and some studies have shown that they're worse at telling. And yet we still hold physicians culpable in some cases for being fooled, so for being human, right? Okay. So now we get, so this is sort of the context we're sitting in, and we get to the really big push that comes after the early 2013 release of the DAWN data from 2011, which was the data about hospitalizations and deaths related to different drugs. And we get the traditional headlines and lots of blame to go around. This is an older survey. I think if you did it today, given the media coverage, the pharmaceutical company line would be higher, right? But we're all products of what we hear in the media, right? Okay, so what we start to see around this time, this is 2013, is the term overprescribing being thrown around, but nobody was defining it. And this is it's a tiny bit of a frolic, but I just wanted to include it. So this is a picture. Just last week at my institution, I was participating in a professional development activity. It didn't have anything to do with the opioid crisis at all. Nothing. Absolutely nothing. And it was an exercise in like understanding how we see things differently and sort of how we have diverse worldviews. There were about 10 pictures, just random diagrams of lots of things all over the room, okay? And you know, just all kinds of things. And in every single instance, the feedback was pretty diverse. We couldn't talk amongst each other. We had to sort of write down what we thought, and then somebody collected the answers, and then they were written on the board. Okay. So this is a picture of a medicine bottle and something like a map, right? So it can mean a lot of things. But in this small group, obviously not scientific, it was just people in my institution all participated in this activity, the response was pretty much universal. Everybody in that picture saw a frightening epidemic, how it's more common, how it's national drug abuse, and it's, you know, and I'm not saying that's not true. It obviously is true, but it was interesting how no one in that room saw anything else, but obviously except me. But I erased mine before I took the picture because I was like, I just have to have a picture of this. Okay. So here's how we reacted. So we got this information in 2013. I mean, we had information coming in, but that was sort of the big push. That was the big alarm bells being sounded. And lots of concern about overprescribing everywhere. And even though the data at that time told us about a lot of things that we should have been worried about. The focus was almost 100% on this notion of overprescribing, meaning patients with chronic pain getting prescription, then taking too much of their own prescription that was given to them and overdosing. Okay. Now that was certainly a small piece of the puzzle, but we have lots of other information that was flatly ignored even by the CDC for between a year to almost present day that I think is concerning. So at first we looked at pain clinic laws, which made sense because in certain parts of the country, corrupt individuals, so truly criminal, people with criminal intent were taking advantage of the fact that many patients with chronic pain did get opioids and using that as a front. Many states repealed their Intractable Pain Treatment Act, which were acts created in the 90s that were intended to assure doctors that they wouldn't be in threat of losing their license if they treated somebody's pain reasonably. And a number of other decisions, but all sort of laser focused on that narrative. Okay. But we were missing, let me do that. Okay. So I'm going to talk more about things we were missing, but for example, this data on that, that Dawn data, for example, did tell us and should have prompted action on the dangers of combining certain types of drugs like opioids and benzodiazepines, which greatly increases your risk of death, the disproportionate dangers of certain opioids, especially in certain patients, some of the risk of suicide that wasn't being fully investigated, the role of primary care physicians in prescribing, which we did catch up to eventually, but we sort of knew it then. And that was just puzzling to me. And so I started to think about, well, how do we explain this? Like, people, obviously very well qualified scientists are looking at the same information and they're choosing to focus on one thing to the exclusion of others. Legislatures don't seem to be even getting the first-hand information. They don't even seem to be getting the full picture. And what is happening? So I looked around and combined some theories of decision-making from behavioral economics, from neuroscience and decision-making, and from medical decision-making literature. And I ended up with this, which is just admittedly one theory. There are others. Essentially, that starts with this dual process mode of decision-making, which a lot of people have heard about, right? So the theory being, and of course it's a bit of an overgeneralization, but the theory being that we've got sort of the slower, more deliberate, more I have to think about thinking mode, and we have the sort of intuitive mode. You don't have to think about it, okay? And you can move things, and we do all the time, from I have to think about it to I don't have to think about it. Every time you learn a new route, so when I moved to Omaha, I had to use my GPS, at first to get everywhere, and then I had to pay attention, and now I'm like, oh, how did I get there, right? So you move from one to the other. Now, we can't be using the thinking mode all the time, or we'd be more exhausted than we already are, okay? Because it takes work, okay? So the intuition side is helpful, right? And it's efficient. But there is a problem, and that is where we are more prone to the effects of our deep-seated biases coming in and leading us to make bad conclusions. Now, there's also, though, just because it's intuitive doesn't mean it's bad, right? Not only is it efficient, but there are kind of two kinds. There's this theory called the fuzzy trace theory. It's a neuroscience concept. And it basically divides the intuitive up into a couple of types. And one of them is, impressionistic thinking. That's where, the deep-seated biases we all have come in, probably some of those things from the media and just growing up in this culture, the attitudes about addiction, can influence our thought process, right? There's also insightful intuition. So once you get very skilled at something, like a doctor or nurse who's learning how to do emergency procedures, you know, after a while, they can just do it. And after a while, they can see, like, without really thinking about it, this person's not doing well, or this, you know, that sort of sixth sense feeling that can be very much based on your, you know, the learning that you've done, right? So, but what we're really concerned about is that impressionistic side. Here are just a couple, and I'm not going to spend a lot of time on it, but these are some of the biases that have been identified. One I want to point out is the availability bias, because it's particularly relevant to opioids, because the more salient something is, meaning the more you can bring it to mind, or the more recently you've heard about it, the more you're going to attribute meaning to it, or like causation to it. And visceral biases, which have to do with things that make you feel indignant, betrayed, or outraged, can be very powerful motivators of decisions that even run counter to your own interest or the interest of like your professional obligations, okay? And that's kind of on the individual level, but if you take it up a notch to sort of the group level, there's been some really interesting work done that I think applies to this area by Sustain and Kahneman and some other folks that are well known. But basically, they've looked at a number of different kinds of policy implementations over time in hindsight, like environmental regulations and some other things. And they've said, look, this is what happens. You get a combination of things, and that can lead to sort of almost universal belief in something and policy enactments based on incomplete information. So here are the things that they really combine. So you get an informational bias where you, and this is very common, we're inundated with news and information all the time, right? So you're often going to have incomplete personal information automatic, okay? And then your tendency to just accept what the person before you said, especially if they seem to have authority to do so, they have a good reputation. Then reputational is really not wanting to go against the crowd. So X, Y, and Z said this thing. So they all said that the source of the problem is chronic pain patients being treated by pain doctors. They all believe it. Even if I'm not sure, part of me is not going to be like, what? I'm going to just kind of go with the crowd and be like, you're right, it is that, right? And then the salience, again, how frequently it comes to mind. So with all the media over and over again, these things just keep going in these big circles that turn into big tumbleweeds. And pretty soon, everybody has forgotten about going back to the original source. Law students, by the way, this also happens when people quote a bunch of other people that have quoted other cases and studies. Be careful of that. Okay, so that's my free advice. But here's just this is just a quote from one of the articles explaining that it matters because we spend money and resources and effort on policy enactments that aren't tailored to the problem. Okay, so how do we fix this? There's a number of things, but I'm just pointing out one technique that maybe help check ourselves a little bit when we're making decisions, and that is something called the forcing strategy. And one of the more common, simple, it's nothing fancy either, that's the thing I love about it, is like a checklist or a framework or something to make you step back and look at what you were trying to do in the first place when you enacted a policy or a practice. Okay. Which brings me back now to the ideas about prescribing in the aftermath. Okay. So we've got studies and policy documents galore. I can have 50 slides just with pictures of different organizations that have put forth policy documents and legislative enactments and state licensure board regulations. But The interesting thing is I have not been able to find a single one that defines inappropriate prescribing, overprescribing, misprescribing. It's almost like pornography. You're supposed to just know it when you see it. Only the lawyers will get that joke, probably, but sorry. But I actually don't think it's that obvious. Okay. So as I've looked through the studies about the kind of things that happen when people prescribe and people get hurt, I've tried to come up with 6 proposed categories that I hope might be helpful. And I think they might be helpful too to like prescriber groups and professional boards and associations as they think about what do we mean when we put forth these guidelines and what are we trying to avoid. Okay. So just some basic preliminary definitions I'm going to offer. I'm going to start with inadvertent prescribing. Inadvertent overprescribing, I'm sorry. I think this is important for the reasons that I mentioned earlier, that a careful prescriber can be actually fooled into prescribing something that they believe sincerely is appropriate. And there should not be culpability to that prescriber for doing so, because they are only human. Now, the caveat is, if you actually had a system, and there are some states, theoretically, that have, like Nebraska's got a very good PDMP in terms of real-time reporting, in terms of comprehensiveness of the information, because they pull all medication information. But it doesn't talk to Iowa or Kansas, so if you happen to be just in Nebraska, maybe you could catch it. And if the person's not using fraudulent identification or anything else, right? So I don't think we should hold providers accountable for a careful, thorough, but mistaken prescription. Okay. The next one's pretty easy. Corrupt overprescribing. We heard a lot about that from Stacy Vino earlier. Horrific stories, all of them. But this is a little bit easier because it is those kinds of stories. There's also a lot of maybe older, especially when we had more paper scripts, but a lot of like, I'm on the parking lot running the side operations, like a food truck, but a prescription truck or something, strangely. Okay. Then the next group is where I think we exerted a lot of our policy energy, which is where people prescribe or continue to prescribe when there's little to no evidence of therapeutic benefit relative to risk. So if it's not helping, if there are dose escalations that are needed that seem bizarre, if you have indications or concerns that there is a substance use disorder developing, right? That would be, and you ignore it, that would be qualitative overprescribing. And interesting, a lot of early policies specifically excluded but not after surgery, but not after surgery, not anybody with cancer, which is a little strange to me because there's a different, cancer is obviously a serious, complex, chronic illness, but it's increasingly a chronic illness that may or may not be painful. So to just put a blanket seemed strange. Okay. The next 3 are the ones that I think didn't get the attention they deserve, certainly based on the evidence of harm that we have. So it's quantitative overprescribing, and this is the surgery example, the dentist example, where somebody is prescribed way more medicine than they're likely to use. So sometimes this is often I think this is reflexive prescribing. Any profession, people like to get into habits and trends and ways of doing things, right? It's a lot easier, and that's often in that I've learned how to do it. I was in residency. I was taught after the surgery, give them that script and send them home, and I just keep doing it that way, right? Because I'm too busy to sit and think about that patient at that moment. And again, I understand because it is really busy, but we need ways to help people not make those mistakes. This is particularly concerning because over time, I think think it's correct for me to say that at least for the last 10 years, for every year that it's been assessed, more than half of the people that initiate new prescription opioid misuse are not the people for whom the prescription was written, right? They are teenagers or youngsters or even older folks stealing, borrowing, getting somebody to loan them a pill. It's not been prescribed for them, okay? And so, well, I'll give you an example. So, due to the availability testing example with this as an example. So, Professor Hodges said earlier, which is a true statement, that 80% of the people that died from an overdose initiated or started with a prescription. A part he didn't say, though, is 80% were not the people for whom it was written for, okay? But when you hear just that, and the CDC said this, and lots of people said this over and over again, everybody thinks, oh, it's the people who it was written for, okay? Not that that doesn't happen, it does. But if we're ignoring the other way people get initiated, we're not preventing a lot of the harm that we should be worried about, okay? Multi-class overprescribing, very significant problem. We've absolutely known about it for a long time, and hasn't really gotten serious attention until the last maybe 2 years, I would say. And it should have been getting more attention. So this is combining opioid prescriptions with benzodiazepines or to people who either have binge or heavy alcohol use, both of which significantly increase your risk of death with overdose. And then the last category that I think gets almost no attention and is concerning to me, which is withholding appropriate opioids. Doctors or practices that do blanket exclusions. Doctors who are doing too rapid of tapering, not based on patient assessment information function, but on some perception of a legal requirement, or sometimes there actually is a legal requirement. And then the other big one that makes my blood boil, and I'm sure my folks that work in addiction, there's a bunch of people, there's a group, right, that work in addiction treatment, or did we lose her? This is one. You? Okay. I thought there were several. Anyway, you'll be like, yeah. Everybody else will be like, I don't know about that. Which is that we continue to endorse treatment for substance use disorder. Sometimes that's based on 12 steps alone and does not incorporate medication-assisted treatment, which is the absolute evidence-based best treatment for addiction in combination with other things, right? But it's strange because you wouldn't have that kind of endorsement even by governments in some instances, probably in any other part of medicine, and that would be gotten away with. But, so it's very frustrating. Okay. So here's just this is not exhaustive, it's just a quick representative list of the kinds of enactments and how they match up with the definitions I'm sort of suggesting. So I think inadvertent overprescribing, that's definitely a PDMP if you can get up to speed where they really are in real time and talking to each other, right? I actually think we have corrupt overprescribing pretty well handled. I don't know what other remedy we want to put on there, because for people who engage in corrupt overprescribing, there's literally every branch of government and type of enforcement available, right? So I think we have that handled. Qualitative overprescribing, again, there are a number of things, right? PDMPs, professional prescribing guidelines, licensure and discipline, and tort actions like wrongful death or malpractice, right? And quantitative overprescribing, I think, is a little bit different. This is, I think, where it might be reasonable, as long as they're done reasonably and allow the practitioner discretion to make patient-centered decisions, that to say, like, hey, if somebody has dental work, they don't need 60 days of OxyContin you know. They probably could get by with 3. Like, let's find ways to reevaluate it. Day 3 if things are still bad. And actually the CURA Act 2016 had some very good things in it, including further encouragement of secure electronic prescribing, so that you don't get into the problem that people used to always talk about with paper prescribing, which was maybe we're in a rural area, maybe there are other reasons. I don't want to have the patient have to come back, travel back here to see me to get another prescription. Now you can, in some instances, take care of that. The other thing it did was allow for partial fills. So doctor, reflexively prescribes, but now it's not just up to a doctor. I can take, or nurse practitioner, I can take the prescription to the pharmacy and say, I know it says 60 on here, but can you give me just like 3 days worth? Or can you give me 10? And then they can hold on to it, and I have the opportunity to come back once if I need it. But that is important because it really cuts down on all that stuff in the medicine cabinet, right? All the stuff that's right for diversion. Multi-class overprescribing, PDMPs, if there are multiple prescribers, it's probably not going to fix one prescriber deciding to do that. But I think guidelines, this is, if it's in guidelines, it's like way down at the bottom, like almost in fine print, like that I just moved right up to the top, as far as I'm concerned. Like, that's really dangerous. That should go up the top, okay? Okay, and then we don't really, so underprescribing, I think, in fairness, I probably shouldn't have just put questions. When it comes to people in pain, I'm not sure we actually do have anything that protects them, but in terms of people who have substance use disorders, I do think they're much more, in the bill passed earlier this week, there definitely is more support for the idea that we need more access to care, more endorsement of medication-assisted treatment and other evidence-based treatments for addiction. So that's actually hopeful, or helpful. Hopeful? I don't know. It's too late. I can't. I should just, now's when I should dance because I don't want to talk about it. I can see this card. Okay, so I think I actually kind of inadvertently covered all of this as we were talking through each category, and I know it's late. So I'm going to look through here and just see. One thing I wanted to just mention that we also have to be quite cognizant of our resources and our unintended consequences. And I think we've heard multiple times today that we have sort of moved out of prescription opioids as being the most risky component, and we've gotten moved into people more often turning to heroin and other illicit forms of opioids. And there have been a couple of articles on sort of the effectiveness of PDMPs and also perhaps the unintended consequences. So the evidence is quite mixed on PDMPs, and it depends on what's being measured as well. But one thing I would point out that this is the first one I've seen that I hear that, I don't know if Mike is involved, but Corey's got something in the press, and pretty much the same thing, that a side effect or an unintended consequence of a rigorous PDMP system is that you see, if you stop just measuring like number of prescriptions and really look at overall deaths from opiates, the rates of heroin deaths are going up. So you like whack-a-mole your way out of this thing, so it's not making it better. You tamp down the prescription problem, but now people are turning to more dangerous, less predictable, more deadly things. And actually there's a recent study, I didn't put it in here, but recent study by the same group that did this one, which I was talking about in a minute, but that looked at first drug of initiation over time among people seeking treatment for substance use disorders. And 2017 is the first point, and if anybody's interested, I can send you the article, but the first point at which the first opiate of initiation is now heroin and not a prescription drug. So that's actually not all that great, right? Because that's more dangerous. Here's the other thing that I thought was incredibly interesting. So just now, we're finally digging back and going, well, when we say people got addicted from their pain medicine, what does that mean? What do we know about their characteristics, how that happened, what their predispositions were, like in a really serious way? And this group found that, and this just came out last year, this group found that of the patients who were iatrogenically addicted, meaning their exposure did start with a prescription written for them, right? That over 90% of them, when you trace back their history, had significant prior misuse of psychoactive substances. So they essentially had a substance use disorder when the medicine was prescribed, okay? Which makes sense when you think about addiction as the triangle of genetics, environment, and exposure, right? Exposure alone doesn't do it. The more exposure you have, the more risk you have, but you have to have the environmental factors and the genetic predisposition all working together. But I thought that was interesting information, and actually leads to, I think, the logical conclusion that what we really need are much, much better risk assessments. We need to reimburse physicians and other prescribers for spending the time they need to spend with these patients who have incredibly complex health needs, and we don't, right? Okay. And then the last thing is, and I won't bore you with all of it, but there is just a significant risk of suicidality and completed suicide with people that have chronic pain. And again, I don't think it's actually, it might be in the VA, it's in the VA guidelines. I think those are the only guidelines that suicide is in. Again, that should move up right behind. It should be multi-class, you know, certain kinds of opioid prescribing and suicide risk should be all up there together. But for some reason, we're not doing that. Okay. And now just to just demonstrate that we're finally getting a little interest in the medical community, they're starting to do studies about, well, what do we send people home with? Because, you know, it's all been anecdotal. Everybody knows I've had a procedure I've been sent home with. I still have 100 in my cabinet. You know, lots of people have that experience. But we're starting to get some validation of that and how reflexive it is. This one was just somebody who, this was just happening in a population group, but 48% of the patients that got sent home used less than half the medicine they were sent with. So they weren't assessed very well in terms of what they were going to need, right? And 94% of them had leftovers, and I didn't include that similar percentage, it was around 85% to 90% had no idea what to do with the leftovers, right? And then this one is from obstetrics and gynecology. So they were prescribing people 30 pills to go home with, even though for 24 hours before their discharge, they had pain scores of 0 and needed no medicine in the hospital at all. 0, and they're like, we'll just take it anyway, okay? So, it's a bit strange. There are a few things in the Senate bill that have to do with safe storage and disposal, which I think is a good thing, like, let's keep working on that, including finally some attention to the problem, the problems you can still have in hospice with leftover pills, but again, hospice, palliative care have been completely ignored, you know, for good reasons. Like, nobody wants to go back to that time when people were screaming in pain at the end of their life, I don't think, right? But that doesn't mean problems with, like, leftovers aren't real, right? It doesn't mean that those people might not have relatives who have a problem. They need to know about safe storage, right? And this just demonstrates that in at least one study, there's a 10-fold risk of death if you co-prescribe benzodiazepines with an opioid. So that's a serious, serious problem. And then a problem that is beginning to get a little attention, but the medical community acknowledges that they still don't have it right, which is the complete lack of knowledge on how to taper people who have been on opioids for a variety of reasons. If you read anything, I would say get this. This is a great article from Travis Ryder about his firsthand experience. He had some horrible, multiple crushing injuries, and so he was, I don't know how many, I can't remember how many surgeries, 5, 6 surgeries. So he was on some dose of opioids for over a long period of time, until like the last surgery. And then nobody at Hopkins, okay, and he was at Hopkins, so it's not like he was at a place where, oh gee, they don't really know. Nobody could tell him how to get off of them. Nobody. And this he recounts this sort of misery and pain. Then they would say, well, call the MAT folks, the medication-assisted treatment. So and they would say, well, no, like it doesn't sound like you actually have a substance use disorder. You just need to wean up. Then you go back to the surgeons. Well, we don't know. Just cut it in half, go half down. And he was like in horrible withdrawal, suicidal for the first time in his life. He's really thoughtful. I don't want to say it's a great story because obviously it's terribly depressing, but it's very informative and well written, and I think you'll learn something. So the other thing I continue to be worried about and want to watch is the fact that people with chronic pain, whether or not they take opioids, whether or not they want opioids, but they're just associated with opioids at this point, are having a hard time finding doctors anywhere that'll take care of them, whether or not they take medicine. Okay. All right, so that's just my little framework as it sits now, and my hope is that it might be helpful perhaps as people think about evaluating policies, everything from hospital policies about prescribing to state enactments, and looking to see if previous policies are actually achieving what they hoped when they